Okay, so throughout this presentation, we're going to review the chain of survival. We'll review and discuss the updates and how all of these apply to us as first responders. Also going to discuss some of the coordination of our efforts in the field. I'm going to give some items for things for you to consider and direct you to review the protocols. Here's an overview of the chain of survival. It starts with the recognition that an emergency exists, followed by activation of the emergency response system, followed by CPR with an emphasis on chest compressions, then to early defibrillation, advanced cardiac life support, and post-arrest care. Now, throughout this presentation, we are really focused on this as a work-centric type of program. However, please consider how you would respond if you're presented with these kind of situations when you're out in your own personal time and environment. So you can recall that we're going to do a pit crew style approach to the performance of CPR when in our work environment. So always recall that BLS comes before ALS. Let's build a solid foundation from which we can develop everything else. Right away, we're going to develop a plan. Is this a viable patient? It's going to be based on pre-arrival instructions to the caller. If bystander CPR is being performed, is probably the biggest one, and litany of other information that can impact the scene and potential outcome. So we'll form our impressions off of those things once we arrive. We'll develop a plan. We'll make those assignments, compressors, airway, and somebody taking information. So be sure that we stay focused on our task and try to limit those distractions. That is helped by maintaining a safe scene throughout this entire time and just maintaining that professional decorum throughout. This is obviously a bad time for a lot of people, and we want to maintain a certain level of professionalism throughout. So luck favors the prepared. A lot of people want to ascribe luck to certain outcomes that are positive. I like to say people were just well prepared. When you're prepared, you're confident. And when you're confident, you can run a very proficient and effective scene. So in doing so, you want to maintain those assignments that we make. We want to switch that compressor roll every 2 minutes. If we make that decision to transport a patient, we want to pull all available personnel to run a safe and efficient transport. We want to coordinate our efforts, and this goes beyond assigning people tasks as far as compressor roll and managing the airway, but coordinating our efforts for patient movement. The example that we like to use is if we move a patient to the top of a staircase, let's do a round of CPR before we transport them down the staircase. A round of CPR consists of 5 cycles of 30 compressions and 2 breaths. Let's get them down to the staircase. We do another round of CPR, 30 compressions and 2 breaths. So let's coordinate those efforts to limit our hands off the chest time, otherwise known as a no-flow time. We don't allow for our hands to be off the patient's chest for longer than 10 seconds. So that means we don't even stop our compressions when we're intubating our patient during the ACLS protocols when those take over. We want to have continuous discussion during the care and transport of the patient. This means if you see somebody that is not doing compressions very well, you need to verbalize that. For example, that maybe on the test is you notice decreased chest recoil. Okay, so things like that. Let's keep the conversation moving with the care. This is all supposed to lead to better patient outcomes. And as always, please document everything that you do. If you don't document it, it never happened. Our QSC committee does a great job in reviewing these cases. It is, after all, practicing medicine. So we learn from people's failures, and we also learn from people's victories. So let's work together to improve everybody's outcomes. Let's review the links in the chain of survival, starting with recognition and activation. What does this mean to first responders and healthcare providers, and how is it applied to us for activation? So this basically just means we're going to recognize a decline in the patient's condition and activating our dispatch to send additional resources to our scene. So we can't always rely on dispatch information. We cannot rely on bystander and family information. We need to use that as a little bit of evidence and form our own impressions of the patient. Okay, so sometimes we can't get that tunnel vision, and we've all been in those traps before. So let's recognize that an arrest patient exists and activate the appropriate resources if they're not already on scene. So at the end of the day, we cannot have successful outcomes in our treatment and transport of an arrest patient performing CPR if bystander CPR is not taking place beforehand. It's highly unlikely. So I'd like to encourage everybody to be an advocate for the patients, the public, and our profession. Take advantage of opportunities to explain why it is so vital for bystanders to learn and perform CPR, even compression or hands-only CPR. Refer interested parties to the public education classes available if necessary. The next steps in the chain of survival are high-quality CPR and early AED use. We're going to focus on high-quality CPR with an emphasis on low compressions. For all patients, regardless of age, we're going to compress at a rate of 100 to 120 times per minute. Where we are applying pressure is always at the lower half of the breastbone or just below the nipple line, but never where the rib cage meets. You can think about 2 fingers widths above that landmark. We want to be acutely aware to allow for complete chest recoil. We'll be working against our own efforts if we don't allow this to happen. The heart is a simple pump, and we want to allow it to have the opportunity to refill its chambers with oxygenated blood. Therefore, when we compress, it can pump that oxygenated blood to itself and to the brain. We want to defibrillate as early as possible. For testing purposes, when the AED arrives, the first thing you want to do is turn it on. From that point, you just want to make sure you follow the prompts. In doing all this stuff, we want to stay organized and stay focused. That's going to allow us to run an efficient scene and efficient transport to the medic unit and to the hospital if necessary. As always, as we do with any other scene, we always want to maintain control. It's a very dynamic environment, and we want to not lose sight of losing control of that scene. Here are a few things to remember. For American Heart Guidelines, an infant is anybody from birth to 1 year of age. From 1 to the onset of puberty is considered a child. That onset of puberty can range greatly from anywhere from 7 to 10, 12 years old. When in doubt, just treat the patient as an adult. Now, for a single rescuer, for all patients, regardless of age, your ratio is 30 and 2, 30 compressions to 2 breaths. Once a second rescuer is introduced, your adult ratio stays the same, 30 compressions and 2 breaths. For infants and children, that changes to 15 and 2. Remember, for infant CPR, adjust your compressions to a thumb encircling technique. The idea why infants and children ratio changes to 15 and 2 is that they typically have strong and healthy hearts. There are special considerations aside, but the reason that an adult typically stops breathing is because of a cardiac related issue. An infant or child heart stops beating usually because of a respiratory related issue, most notably choking. We relieve choking in adults and children with abdominal thrusts. This used to be referred to as the Heimlich maneuver. Your hand placement is your fist approximately 1 fist's width above the navel. For infants, you relieve a choking item through a series of 5 back blows and 5 chest thrusts. For adults, children, or infants, all of these interventions are continuous until the object is relieved or the patient becomes unresponsive. Another side note, for an adult patient that is potentially choking, you need to ask them if they're choking. I realize that sounds a little bit crazy, but you still have to ask them if they're choking. They still have to consent to treatment. They have to consent to your intervention. If they decline your help, just stand to the side, let them try to relieve the item themselves. If they become unresponsive, then you'll just start doing CPR. Okay, the only modification we do with our CPR sequences is for a known choking patient. Before providing a breath, if you can see the item and get to it, attempt to extract the item with your finger or McGill forceps. The remaining notes cover advanced life support and post-arrest care. We're going to continue that coordinated effort during transport. that transport decision should be made early, and again, based on the pre-arrival instructions to the caller, if it was a witness arrest, if bystander CPR is taking place. I like to tell my students that we're really just trying to get a patient to somebody that has more initials behind their name than what we already have. So that's what we're doing at the end of the day, is keeping these people in the game a little bit longer if we can do so. But inevitably, we're going to sometimes have to do that field termination if and when appropriate. We'll cover that in the end of the presentation under that protocol. This whole deal, we're trying to do the greatest good for the greatest amount of people. It's a very utilitarian type of approach. We want to have organized team-oriented approach with clear goals and responsibilities. All team members know their task and perform it well. We're going to know and understand your limitations, but please continue to improve. If you're not very strong with airway adjunct interventions, please ask for help. An instructor will be able to go over these techniques with you and to help you improve. Don't shy away from improvement. Do not transport a patient that is not viable. This will be connected with that field termination guideline. Emergency departments are overwhelmed in this region, and they just can't occupy a room with a patient that's not viable. Data is being gathered still, but please consider the necessity about emergency transport. If we determine that we need to transport this patient, are we really being safe for the crew and the safety of the public? Essentially, it is still a dead body. Are we able to provide effective compressions while in transit? I know this sounds crazy. This is not a very popular thought, but at one point we were also told to give high flow O2 to everybody, and now they're starting to dispel that. So let's consider and keep an ear out for data that's still being gathered about transporting lights and sirens in a code type of environment that may change in the future. Please consult the protocol for field termination guideline A105. And when in doubt, always contact medical control. Be sure to obtain the physician's name and or ID number. Okay, thank you. This wraps up this presentation for this year. The crews will be called to fire headquarters by station. All the members will participate in the hands-on portion with the feedback mannequin. Each person will take turns performing their compressions and operating the bag valve device. They'll switch every 2 minutes. The members needed to update their cards will stay and take the exam. Again, thank you for watching. I appreciate all your time, and we'll see you out there, and stay safe.